Welcome to Health Frontiers, where we explore the uncharted territories of well-being. I am Dr. Robert Lahita, also known as Dr. Bob. With over 50 years in rheumatology and immunology and 17 years as the chair of medicine at 3 major medical centers, my mission is to simplify complex medical issues for you. Join me as we uncover the latest breakthroughs in health, answer your pressing questions, and discuss nutrition and holistic living. This podcast is all about empowering you with the knowledge and tools to manage your health effectively. Let's embark on this transformative journey together. Welcome to Health Frontiers with Dr. Bob, another episode. Today, we have a very interesting guest to interview. Our new format will be 30 minutes of medical news, thereabouts, and some of the news that happens every month and is quite interesting will be presented to you, the patient, so that you understand more of what's going on, a sort of an enlargement of what you hear on the regular news networks. Today, our first topic is avian flu. Avian flu has been talked about by everybody, and there's a lot of confusion. It's known as avian influenza or bird flu. It's a viral infection that affects birds but can infect humans and other animals. The causes are influenza type A viruses, found chiefly in birds, but also in some mammals like cats and cows. There are 2 strains of avian flu, something called B3.13 and more recently D1.1. The similarities between these 2 strains are great, and one is not more severe than the other if and when you get avian flu. The transmission is spread through direct contact with infected or sick birds and contaminated surfaces, and sometimes through the air. There are various strains of avian flu, with H5N1 being the one that everyone knows, and H7N9 being the most concerning for human health. What are the symptoms in birds? That can range from mild illness to severe disease and death. Some symptoms include respiratory distress, decreased egg production, and swelling. And some of this is responsible for our high cost of eggs. And we all know, those of you out there who are watching, know that eggs cost a fortune, comparatively speaking to like 3 or 4 months ago. But what about humans? Can we get this bird flu? And the symptoms in humans are fever, cough, sore throat, muscle aches, and in severe cases, pneumonia, respiratory failure, and death. Prevention: avoid contact with infected birds, practicing good hygiene, and make sure you cook poultry thoroughly. By that I mean turkey or chicken has to be cooked. And that's a general rule for everyone, because at one of our sessions, we talked about salmonella in chickens and the fact that raw chickens put on a board and cut by a cook could well be infected with salmonella, and unless that chicken is cooked thoroughly, you could be infected. So did the virus spread to dairy cows, and why is that? It appears in cats and dairy cows, as I mentioned, and pasteurization of milk is essential, and pasteurized cheeses are very important. I know there are some advocates of unpasteurized milk and other forms of unpasteurized, say, cookie dough involving unpasteurized milk. And these are very good sources of infection. Vaccines and treatment. What are these things? Are vaccines available for poultry? And they are only for poultry. Antiviral medications can be effective in humans if taken early. And there are anti-flu drugs like Tamiflu, for example, that are available to help control avian flu in humans. What's the impact? Well, the significant economic and health impacts we've already discussed with the cost of eggs, and this affects chickens and chicken industries, and posing a potential risk for a human pandemic. In one of the previous episodes of Ask Dr. Bob, we talked about the possibilities of another pandemic. And it was generally felt among infectious disease experts that another pandemic with something like bird flu was not likely. However, this is requiring that the virus jump from an animal species like a bird or a cow to a human. And it's always possible. And I'm going to tell you something about that now. We surveil bird populations. We are culling infected birds, and you've heard of millions of chickens being destroyed, especially when one of these flu viruses breaks out in an egg center or in a chicken house where maybe 10,000 chickens would be producing eggs for sale. When that happens, these birds have to be culled. They have to be killed. And biosecurity measures are essential, and they are being followed to control outbreaks. Now, my last comment on bird flu is at this time there are 67 human cases reported, and this is since March of 2024. There may be more since that time. And there are 957 infected dairy herds. 957 infected dairy herds. 7% of farm workers that deal with chickens and cows have tested positive for antibodies. Those are the proteins in the blood, like COVID antibodies, but these are proteins against the bird flu. And these have been found in 7% of farm workers. So this virus is being transmitted to humans, but fortunately, it's not causing deadly disease. There have been 2 cases. One lady in Louisiana died, but she was immunocompromised. And there was another child in British Columbia that got the infection, and she did not die, but she was on life support for a period of time in an intensive care. So if you're very, very viable, that means that you're either on drugs that immunosuppress your system, or you have a propensity to getting infections, and we don't know about everybody's immune system, as I've written extensively. Everybody's different. It's like your fingerprint. So if you are a person that is easily infected by viruses like the flu, you may get the bird flu. But again, in humans, it's been very mild, thank goodness. The next topic in the news that you've all heard about are brain injuries among Navy Top Gun pilots. And we talked already on one of these shows about CTE. I'm going to talk about it again. But there's been a high incidence of brain injuries in Top Gun pilots in the Navy. And these brain injuries are because of the extreme conditions of high-speed flights. Now, this was never thought of before, but the brain is a gelatinous mass in the skull, which we call the calvarium, and with rapid movements, it sloshes within the skull, and injuries can occur. These are coup and contra coup injuries where there can be microscopic bleeds when the brain is jarred abruptly. What are the causes? Well, in Navy Top Gun pilots, the intense G-forces and the rapid acceleration and deceleration during these naval Top Gun maneuvers subject the pilots to immense physical strain. The symptoms are headaches among the pilots, dizziness, cognitive impairments, that is, not knowing where they are or forgetting things or having brain fog, and memory issues. Forgetfulness, very common, indicative of traumatic brain injuries, or we call them in medicine TBIs. What are the long-term effects? Well, these injuries can lead to chronic neurological conditions, which affect the pilot's ability to fly their planes, the quality of life, and the longevity of their careers. Research and awareness is going on right now. People are researching and highlighting the need for better protective measures and monitoring protocols to safeguard pilots' health. The implementation of advanced flight suits, helmets, and training programs designed to minimize the impact of G-forces and other flight-related stresses are in progress. Support and rehabilitation provides the pilot with comprehensive medical support and rehabilitation services for them and to manage and recover from their injuries. Now, I segue from this into something called chronic traumatic encephalopathy, which we've already mentioned when we were discussing in our first episode with a professor of neurology, this thing called CTE, chronic traumatic encephalopathy. This is a neurologic condition, and it's a progressive degenerative brain disorder often found in individuals who have sustained repeated head injuries. And by this, it was really described for the NFL and professional football players. But it's not limited to members of the NFL. It can be seen in children, young teenagers who play football, or anything else where there's repetitive, repeated head injuries. Although it was first identified in the 1920s, you may remember it was found in boxers, and they were thought to be punch drunk. I mean, I can remember my father talking about punch-drunk boxers back then. And CTE has gained significant attention in recent decades due to its prevalence among athletes in contact sports and, as I just told you, in military personnel. CTE is caused by repeated concussive and subconcussive blows to the head. The impacts lead to the accumulation of proteins in the brain, which form clumps that slowly spread and kill brain cells. The key risk factors are very obvious. First, repetitive head trauma. By that, I mean when somebody engages in sports like football, boxing, originally described being punch drunk, soccer, rugby, or having a history of military service with exposure to blasts or combat. Now, the unfortunate thing is CTE is usually found at autopsy when one sections the brain. We look at the brains of people who die suddenly or people who die of suspected CTE, and we find it. Before these things happen, the only way to look for CTE is to do a really thorough neurologic examination, and that will result in the diagnosis in many cases. The age of first exposure is important. Research suggests that the younger you are at which repetitive head trauma begins, the higher the risk of developing CTE. Now, in my residency years, when I was training to be a doctor, I was often on weekends a football doctor. And I went out to high schools and stayed on the sidelines and saw a lot of head injuries, a lot of crashes, broken limbs, etc. These head injuries, which occurred many years ago when I was a physician to the team, would be worrisome today. I mean, we would worry about the progression of young people into adult life, and especially if a youngster decides to become a professional football player. CTE is really critically important to consider. And we all know of the illustrious case of a Mr. Hernandez, who was imprisoned for unusual behavior, neurological, which wound up with verified violence where he actually murdered somebody. And unfortunately, he succumbed to CTE. So repetitive head trauma begins early, and the CTE is progressive. The length of time that an individual is exposed to repetitive head trauma is directly correlated with the likelihood of developing CTE. The symptoms are, again, learning disabilities, physical unusual neurologic changes, and emotional symptoms, which may not appear until many years after the repeated head injuries occur. And we've seen the NFL, National Football League, concern themselves with this and deal with this because many players who go into retirement have CTE. So memory loss, confusion, impaired judgment, and ultimately, and unfortunately, dementia evolves. The behavioral changes early on could be aggression, impulsivity, doing things for no reason at impulse, and erratic behavior. The mood disorders are depression, anxiety, thoughts of suicide, and other emotional disturbances. So this is a very serious condition. Some of the motor symptoms, when we talk about neurology, we talk about motor symptoms, which is how you move your muscles, difficulty with balance and difficulty with coordination, tremors or shakes, and Parkinsonism. How do we diagnose CTE? It can only be made right now thoroughly and assuredly posthumously. That is, after the patient dies and we do a brain biopsy, an autopsy. Researchers look for specific patterns of protein deposits and other changes in the brain. However, several methods are being studied to diagnose CTE in people who are still alive, and that is an ongoing research area. Neuroimaging, for example, which is advanced imaging techniques such as so-called PET scans, and the big name for PET is positron emission tomography. It's very valuable as a scan, and they are being developed to detect these protein accumulations in the brain. There are also biomarkers that can be used, like blood and spinal fluid tests that may identify specific proteins associated with CTE. All of this is ongoing research. And finally, neuropsychological testing, cognitive and behavioral assessments to evaluate the symptoms consistent with CTE. So there's no current cure for CTE, and treatment focuses on managing the symptoms and improving the quality of life. The treatment strategies could include medications, prescriptions to manage these mood disorders, therapies like cognitive behavioral therapy, physical therapy, and occupational therapy to support a person's daily functioning. And this is obviously something that we can see in former football professionals, for example, or even in young people who have had tremendous total brain injuries or traumatic brain injuries may have to undergo this kind of supportive care. Counseling, support groups, and educational programs for patients are paramount here, and also for their families. So how do we prevent CTE? Well, it involves reducing the risk of repetitive head injuries. The measures that you can take are protective gear, which I already mentioned, special helmets and other protective equipment in contact sports and in military settings. And by the way, military settings meaning if you're in a battlefield and bombs are going off around you or drone attacks, that can produce CTE, just like playing professional football. Rule changes, implementing and enforcing rules to minimize head impacts during sports, raising awareness about the risk of repetitive head trauma and promoting safe practices, particularly in, junior football in high school or even in grammar school, Little League. Promptly addressing and properly managing concussions and other head injuries. Research in this field is ongoing, with efforts focused on better understanding the condition, developing diagnostic tools, and finding effective treatments. These areas of investigation involve the brain, involving exploring the genetic factors that may influence your susceptibility to CTE, because obviously not everybody gets it, and we want to find out why some people get it. And innovative therapies like immunotherapy, using the immune system to protect against these depositions of proteins, and neuroprotective agents to slow or halt the disease progression. So CTE, or chronic traumatic encephalopathy, is a serious and debilitating condition that's been getting a lot of press lately. And it affects individuals with a history of repeated head injuries, and more recently brought to the fore because of the Top Gun injuries, the Top Gun naval pilots who developed CTE as a result of their flying at great speed and doing these maneuvers, which affect the way their brains slosh around in the skull. So more has to be done, and we need to raise awareness, which is what I'm doing now, and implement preventative measures and support ongoing research. The next news item, in the time we have left, we have two additional items. One is the FDA has recently approved a novel non-opioid treatment for pain. Now, the FDA has been looking for something that would be effective in the treatment of pain. And I'm sure all of you out there who are watching have pain, particularly people with osteoarthritis, people with cancers, people with various traumatic injuries that result in ongoing chronic pain, most of it being neurological. So we have a treatment now, which is not released yet, for moderate to severe acute pain. This treatment offers an alternative to opioid medications, meaning these are not going to be the kind of narcotics that cause addiction. And it's potentially reducing the risk of addiction and side effects associated with these opioids that a variety of doctors will prescribe for you. Now, it's okay to take an opioid when you're in acute phase, but if you've got a chronic disease that causes pain, as many of my patients I find become attracted to these medicines and dependent on them, and that is called addiction. And we don't want that. This novel treatment is expected to be available soon, and we can use it in clinical settings, and doctors can prescribe it. It's a significant milestone in pain management. The drug is called Journavex, or suzetrigine, and it's used in 50 milligram quantities, and it treats moderate to severe pain in adults. It's a new class of drug, and you may be hearing it first here from Health Frontiers. So I want to congratulate the FDA, who have tried to develop a drug like this for many years. I was on a panel actually 4 or 5 years ago talking about non-opioid pain medications, and we were talking about antibodies against pain receptors, but this is not that. This is an actual class of non-opioid drugs that treats moderate to severe pain. The last item I'm going to talk about before we introduce our guest is artificial intelligence. Now, there's a lot of news out there about artificial intelligence, and Elon Musk and President Trump have talked about, and others who have talked about building a $500 billion center for using artificial intelligence to detect cancers and perhaps even treat cancers in people. And how would this work? Well, medical imaging analysis, artificial intelligent algorithms, which we use all the time, can analyze medical images like X-rays or MRIs or CAT scans to identify abnormalities that could indicate you have cancer. Pattern recognition. They use deep learning models which can recognize patterns in you and detect anomalies in tissue samples or in radiologic images, identifying possible cancerous growths. Now, with cancer, the important thing is to get it early. We don't want to get you to have a tumor that's detected long after you've developed the tumor and after it has spread to various parts of your body. It makes it much more difficult to control. And biomarker identification, artificial intelligence now can analyze the genetic and molecular profiles to identify the biomarkers associated with different types of cancer. This is really, really exciting and revolutionary stuff. Early detection is critical. Machine learning models can predict the likelihood of cancer in patients based on historical data, aiding in the early detection efforts. What do we mean by historical data? Well, a patient comes to the doctor and they have had symptoms. I've had heartburn for the past year, or I have pain in my belly for the past 2 years, or I have constipation, and that's been for the past 5 years, chronic constipation. And you ask, have you ever had a colonoscopy? And they say no. Have you ever had an esophageal gastric look with an endoscope? And they say no. So what this precision medicine does is we give this information to artificial intelligence, and it can help tailor treatment plans and procedures that are necessary to diagnose your cancer. And that's exciting. By analyzing various data points, including the genetic information that you have in your family. For example, do you have a sister with breast cancer? Did your mother have breast cancer? Did your great aunt have uterine cancer? On either side of the family, artificial intelligence takes that data, analyzes it, and produces a likelihood that you may be either developing a cancer or have a cancer. Automated diagnostics. Well, artificial intelligence systems can provide automated diagnostic suggestions to doctors who are radiologists and pathologists, improving the accuracy of the diagnosis and reducing human error. unfortunately, there have been instances where a tumor or a lymph node is biopsied and it comes back as non-malignant, and the patient goes on 3 or 4 months later to die of a cancer that was undetected. Artificial intelligence may prevent that. And I think it's very exciting because everybody's been talking about this, but very few centers have actually used artificial intelligence in a very meaningful way. And again, risk assessment is important. Artificial intelligence can assess patient risk factors and help in monitoring high-risk individuals for the early signs of cancer. And then something that we use in medicine, which I'm going to explain, called histopathological analysis. AI can assist in the examination of a biopsy sample, and it can identify malignant cells with high precision when a pathologist may miss it. He or she is looking at a microscopic slide and hoping to see malignancy so that he can go on and tell the physician, the treating physician, to go ahead and treat you for this or that cancer. That often doesn't happen. AI is going to help with that. And then data integration. AI can integrate data from various sources. For example, your medical history, as I mentioned, imaging, your genetics and genetic data, your exposure to environmental toxins, where you live, and what you were next to. For example, a toxic waste dump, for example, which gives us an algorithm and the likelihood that you may be prone to certain kinds of cancer. And so the cancer risk is going to finally be identified using AI. And lastly, AI-powered systems can monitor patients in real time, detecting any changes that might suggest the development or the progression of a cancer. This is very exciting news, and this is part of Health Frontiers with Dr. Bob. This is what we are all about, talking to patients and people about the new advances in medicine. And now I'm going to introduce our guest. Our guest today is Dr. Toghrul Talishinsky. Dr. Talchinsky is the Director of Robotic Surgery at St. Joseph's University Medical Center, Chief of Bariatric Surgery at St. Joe's, and Director of Minimal Surgery, the Minimal Surgical Fellowship. Am I right?
Absolutely correct.
Yes, good. And he's delighted us by appearing today about a topic that is very, very important and very interesting because of all that we've heard about the GLP-1 weight loss drugs. And you were a pioneer in bariatric surgery, and actually long before the GLP-1s, I'm sure you were doing weight loss things. And could you describe what exactly that is all about?
Dr. Lahita, thanks so much for inviting me, first of all, coming here. I know we work at the same hospital, but this is kind of first time us meeting each other on the podcast.
Yes.
With regards to weight loss, right, there are many options for patients to lose weight. But before discussing options, let's take a second to discuss what it actually means to be obese and overweight.
Yes.
The rate of obesity in the United States have skyrocketed. Even in the past 20 years, it went from less than 32%. Currently, 42% of U.S. population is obese. 42%.
Wow. And do you define obesity with BMI?
Correct. So there's a gradual progression to move away from BMI as a description of obesity. Mm-hmm. However, right now, that is the best tool we have that's widely used. But that will be gradually be changing. But so far, for the sake of today's discussion, let's just focus on BMI.
Right.
BMI stands for, I'm sure, as most of viewers know, BMI stands for body mass index.
Right.
And that's a weight to the height ratio. For example, when someone is 300 pounds, that's different if you're 5 foot or 6 foot tall. The taller we are, technically, the heavier we can be. Mm-hmm. Just a couple weekends ago, there was Super Bowl. One of the linebackers was 360 pounds, but he was 6'6".
Wow.
That's not a morbidly obese person, right? So then we'll come up with these numbers for the BMI. So the ratio between 19 and 25 is considered ideal body mass index. 25 to 30 is overweight. And that's where actually most of the U.S. population is, in the overweight region. Mm. BMI above 30, now we're in the obese category. And there are different classes of obesity. And the reason description changes is now the weight is not just a number. It's affecting our health, such as we can get diabetes,
yes,
blood pressure, cholesterol, back pain, joint pain, shortness of breath, sleep apnea. There's been multiple links between obesity and multiple malignancies and cancers. You mentioned earlier about getting colonoscopies and endoscopies. There is direct relationship between obesity and esophageal cancer, obesity and colon cancer, breast cancer. They go hand in hand. There have been dozens and dozens studies showing the relationship between obesity and malignancies.
Right.
And cancer.
We think of that more as, and I'm writing a new book on epigenetics, and I think obesity is really an epigenetic problem. It's an environmental cause of cancer. And would you agree we're seeing in cancer more in young people because of obesity?
Absolutely. There's no question about that.
Yeah.
Obesity in general creates inflammatory state, and with increasing inflammatory markers, exactly what you mentioned, there's increased a whole array of issues. But going back to the BMI, 30-35 is class 1 obesity, 35 to 40 is class 2 obesity, anything higher than 40 is a morbid and severe obesity. So clearly, as we define it differently, the treatment plan for them changes dramatically. There are multiple studies shown that what is the success rate of the patients and population if we just told them just go exercise and eat healthy? What is the percentage of patients who would able to lose weight, but very importantly, to keep it off? Almost everyone's able to lose 5, 10 pounds, 20 pounds within a short period of time. But obesity is a chronic condition, just the way conditions you are treating, Lahita, they're chronic conditions.
Right.
So we're not discussing just 1 month, 3 months, 6 months. We're discussing years and decades of treatment that will last with the patients for that period of time. And only 5% of the patients are able to keep it off. So 95% of the patients who start dieting actually end up heavier than they started dieting beforehand.
Wow. That's very important for our viewers to hear. Those people, you might say that again, who diet, lose weight, and then they wind up becoming heavier than when they started dieting.
Only 5% of the patients are able to keep it off, right? And that's the reason we started having different tools to help the patients, right? Be it medications, injectable medications, pill medications, or surgical weight loss. These are the different tools we provide for our patients, right? Just the way I didn't walk today to your podcast. I drove a car, right? I could have walked. It would have taken me a couple hours, but I took the most effective tool I have, which is a car, right? In order for me to get here expeditiously so I'm not late. So same thing, we have different tools we provide for our patients depending on the spectrum of this disease process. And it's extremely, extremely important to understand obesity is a disease. It's been acknowledged by American Medical Association as a disease. It is not just issue, it's a disease. Just the way blood pressure disease, diabetes is disease, obesity is disease, it needs to be treated, right?
Yes, absolutely.
So based on that spectrum, based on what patient conditions have, if they have diabetes, they have cholesterol, blood pressure issues, sleep apnea, our treatment modality changes, right? You mentioned injectable medications such as GLP-1s, right?
Yes.
You cannot...
The semaglutides, for those of you who only know semaglutides.
Right, semaglutides, Ozempic, right? The most common brand name everyone knows, so forth, Wegovy, you name it, right?
Most of these are for diabetes. So my patients are saying, I can't get the semaglutide because I don't have diabetes. So I understand there's another drug called Zepbound that just came out just for obesity. Very expensive. I'm sorry, I interrupted.
Sure, no, please, please. With regards to these medications, right? These are, right now, it's kind of, we're going through the fad phase of these medications. And anytime we're going through a fad phase of anything, be it surgery, medication, we need to use caution. Unfortunately, some patients who should get these medications, like patients such as you mentioned, are not able to get them. And some people should not be on these medications or taking them sparingly, right?
Right.
There was actually very interesting. I love South Park. I'm not sure if you watched the cartoon or not, but there was a whole
Yes,
show
South Park is
dedicated
great.
just for
Yes.
weight loss medications.
I didn't know that.
Yeah.
I have to look it up.
And with regards to who should get this medication, right? Initially, they've been around for over a decade. And initially, it was a compound for diabetes, as you mentioned. It changes our insulin secretion, glucagon secretion, our understanding of that, and truly helps with that. But one of the main effects of this medication is it decreases gastric motility. In simple terms, it keeps the food in the stomach for a longer period of time. So stomach is a muscle. We eat the food goes into the stomach and then pushes the food to the rest of the intestines. Once the stomach is empty, we feel hungry. So this medication keeps the food in the stomach for a prolonged period of time. So forth, we feel fuller and we don't want to eat.
And
right?
some people actually get nausea.
So nausea, some GI issues, cramping, abdominal pain, there are a lot of side effects involved, unfortunately, with these medications, right? Statistically speaking, 15% of US population, 15% of the United States population at one point were on these medications. And this number actually underestimates because a lot of patients are on the compound version of this medication. So it's very difficult to actually track and come up with a percentage of that. I meant actual brand name that's FDA approved version of these medications. However, over 75% of these patients stop the medication within a couple months. Some of that is what you alluded earlier, such as insurance coverage. They're expensive medications. Some of that is due to side effects. Some of those side effects you mentioned were abdominal cramping and so forth. If it's mild, we tell the patients, please continue. But some can be pretty significant. Inflammation of the pancreas, pancreatitis, severe constipation, nausea, vomiting. There's a condition called gastroparesis where stomach stops functioning, period. And that will last for most of the patients lifelong, right? That being said, for a lot of patients, these medications have been a true lifesaver. It's been a hope for them, hope to lose weight, able to keep it off. But the important consideration for the patients is these medications are meant to last for the rest of your life. These are not short-term medications. So prior to initiating them, any version of them, in-depth discussion needs to be held with the patient that once you started losing weight and we stop the medication, you will regain weight back. And that's what all the studies have been shown. Over 92% of the patients who stop the medication within 6 months regain their weight back.
And that's due to cost or due to the fact of the side effects?
Why they stop the medication?
Yeah.
Due to both. Due to both. It's very difficult to take medication lifelong.
Yeah.
I mean, you treat conditions for the patients that are chronic.
Yes.
Compliance is always an issue.
Right.
Compliance
is a big one.
Yeah. And your question earlier was which medications for diabetes, which ones for weight loss. It's the same compound, just with a different label. For example, Ozempic is indicated for diabetes. There's a different compound. There's a different brand name called Wegovy. It's all semaglutide. That has indication for weight loss. There's pretty much exact same compound, tirzepatide. There's a Zepbound version of it, which you mentioned is for weight loss.
Yes.
And there's diabetes version, which is Mounjaro.
Yes.
But overall, similar medication.
Same. Yeah. Right. Very, very impressive. Now, just while we're on the medication point, there are counterfeit versions which are not only dangerous but are actually to be reported because they can cause death or severe illness. This has come out in the press just recently. And have you heard about anybody?
Absolutely. We see a lot of patients in the office who are on what we call compound version of these medications. The Obesity Society, actually, one of the main societies, as name suggests, that deals with obesity, actually published a very strong statement cautioning patients using this type of medications. However, due to cost issues, unfortunately, patients do use these medications. But that being said, some patients do find relief in them. They do find benefits of them. But unfortunately, right now, it's kind of black box, right? Black box.
Yes.
It's extremely important for the patients to understand that when we seek treatment for obesity, we need to find a place that doesn't just offer one medication alone. That we're not just selling the medication, we're prescribing the medication. Those are two different things, that we're not making income from giving you that medication. We'll provide dietary and nutritional support. We'll provide behavior support, psychiatric support, right? To make sure the coping mechanism with food.
Very important.
And it's not just a medical part of it, but we also provide procedural and surgical part of it as well. So in order to get the full benefit, it's very important for the patients to seek comprehensive care for any disease, especially obesity.
Yeah, this is a real problem for a lot of patients. I would say, and I see so many chronically ill people, I would say that roughly 70% of the patients I see are obese. Some of them, and I'm sure you're going to talk about this, have had bypass procedures, have had sleeves placed, and those are probably watching right now, and they know themselves how the sleeve has or has not worked, how they bypassed the gastric bypass, and more intense surgeries besides gastric bypass, which I'm sure you're going to. And they always come to me saying, well, I'm not compliant and I wound up drinking milkshakes or sugar drinks and I've gained a lot of weight back. And there, I think that we have a connection to the brain and the body, which is the endocrine system, perhaps, the glands, pushing patients to violate their own diets.
So let's take a little time discussing that, Dr. Lahita, right? Because the best comparison we can make, right, when we discuss obesity, when we mention obesity as a disease, there's a lot of little pushback despite being recognized as that. Let's draw a little parallel, if you don't mind.
Sure.
Let's draw a parallel between obesity and cancer. When we treat cancer, we use medications, we use radiation therapy, we use surgery. Sometimes surgery alone is a cure. That's all patient needs. Sometimes they may need chemotherapy afterwards, medications afterwards. Sometimes some patients, depending on the stage of the cancer, may need neoadjuvant medications to start with, to shrink the tumor down a little bit, then do the surgery, then medications afterwards as well. Sometimes, unfortunately, no matter what we do, cancer can always come back. That's the reason they follow patients for life.
Yes.
We don't blame the patients for that, but it's a disease issue. Same thing with obesity. Depending what stage we start with the patient. Sometimes we start with surgery alone. Sometimes medications and dieting, and then introducing surgery, and then maybe following with medication. Sometimes medication, sometimes surgery, then medication. It all depends what stage we're at. And despite all the efforts that patient can put in or we can put in, unfortunately, obesity can always come back. Just the way there's a comprehensive care and multidisciplinary care for cancer, same way we provide multidisciplinary and comprehensive care for the obese patients. That's what our patients deserve, and that's what we provide. Now, there's impossible to have one fix for the whole disease process. Sleeve gastrectomy, gastric bypass, they're the most effective tools we have. However, they cannot be the only solution. Same thing with Wegovy, Zepbound. They're important tools we provide for the patients, but them alone cannot be the only solution provided for the patients. There was a recent study published. I enjoyed your 30-minute introduction about the news, comparing long-term costs of weight loss medications to the surgery. Within less than 1 year, surgery was cheaper than weight loss medications.
I believe that. That's very interesting.
And surgery provides a long-term results versus just medications alone. However, some patients, once again, tailoring individual approach to each patient, I think that's the key.
Do you give psychological support for patients? Because the patients I see who begin to gain tons of weight after, say, a gastric sleeve is placed, and you might want to mention how you do that with laparoscopy robotics. But when the sleeve is placed, I mean, it's not one patient, it may be 10 or 15 that I see a year that say, well, the sleeve didn't work, or I didn't like the sleeve and I had it removed. Is that something that's common?
So the procedure itself, you ask how we perform it, is performed via 5 couple tiny incisions. Surgery itself maybe takes around 30, maybe 45 minutes. A very quick procedure. Safety-wise, having a sleeve gastrectomy is safer than a gallbladder removal. That's been studied, that's been proven. Once again, it's extremely safe procedure. However, not losing enough weight or weight regain, both of them are possibilities. Some of them are due to technical aspects of the procedure, how the sleeve was done. Doing a sleeve will remove stretchable portion of the stomach out. That portion of the stomach is responsible for secreting certain chemicals, certain hormones, such as ghrelin, which are responsible for hunger. So usually after the procedure, patients have significant less hunger, less desire to eat food. So we end up eating less food. And obviously leftover stomach is pretty small, which can only accommodate small portions of the food.
Right.
But as you mentioned earlier, there's certain behavior changes that patients need to comply with. And that's the importance of a long-term follow-up. It is not uncommon for patients who see me almost 8, 9 years from surgery. They'll bring pictures of their children and so forth, and come in for the lab checks to make sure, hey, I'm doing well. I'm still eating what I'm supposed to eat. I'm still doing this. Hey, I feel like I gained 5, 10 pounds. What do you think is the issue? Long-term follow-up is absolutely key to make sure that we lost the weight and able to keep it off.
Is there an age range where you can do this procedure? And I think of pediatrics. I'm not a pediatrician, and I'm sure you're not, but the pediatricians are telling me that children are as obese as their parents. And this is a big issue because they come in, and if you go to Disneyland or Disney World, you see a family, not necessarily from the Northeast, but say the Southeast, that they're all obese. The father's obese, the mother's obese, and they may have 3 children who are each obese. When do you start worrying about this?
Excellent question. So there's definitely a genetic component to obesity. There's no question that's been proven. And some of it, of course, is behavior, right? If we're in the same household, chances are we eat similar type of food. We have similar activity level. All those things definitely influence our rate of food intake and so forth. A couple of years ago, I believe 2 years ago, American Academy of Pediatrics published an almost 96-page, almost 100-page document with regards to treatment of obesity in children. And the reason for that is pediatricians started treating adult conditions in children. Children are not supposed to have high cholesterol. They're not supposed to have sleep apnea. They're not supposed to have type 2 diabetes or hypertension. So pediatricians, once again, started treating adult conditions in children. And this prompted this whole change in philosophy treatment of children obesity. And in this document, there's absolutely, it's a great first initial step. We should definitely refer these children to comprehensive care, which we do have St. Joseph's Health, where we provide dietitian, nutritional support, behavior changes. Some children do benefit from medications, and we absolutely offer procedures for adolescents as well.
Do children get semaglutides?
They do get semaglutides. Semaglutides have been approved for 12 and up.
12 and up?
Yes.
How about the surgery, the
Same
endoscopy?
thing.
12 and up?
Yeah.
Wow, that's pretty interesting because, you know, as you've heard, and I haven't reported this newsworthy yet, perhaps our next episode, the incidence of cancers in young people, startling, actually really startling, and nobody knows the reasons for it. So obesity is probably a major factor in that.
Absolutely. And adolescents,
Yes.
they respond to medications and surgery way better than adults.
Mm.
And the long-term results, which also has been published. So I'm stating both from professional experience
Mm-hmm.
and the nationwide studies. They have longer and better results than adults. And I would say that's one of the most gratifying things in my career. When I meet a 16-year-old, they'll come with their parents. They'll sit on the third chair behind in a hoodie. Wouldn't say one single word during initial consultation.
Right.
I'll meet with them for months and months and months. And once they're ready, we'll perform their weight loss procedure. And you see them after a couple of months, they come by themselves, they have a driver's license. After a year or two, they got accepted to college with a scholarship. Completely two different human beings. It's truly life-changing event, both for that child and for the family.
Amazing. Truly amazing. And I hope everyone out there is listening to this. This is extraordinary stuff because this is an epidemic. Obesity is definitely an epidemic. Metabolic changes occur like diabetes early on, type 2 diabetes, and other things affect a person's life and a family's life. What are the developments in the last few minutes that we have? What do you see as the developments going forward?
In the
both medical and surgical.
Well, surgery-wise, it's been interesting to see the transition of what we do. You look back at the history of surgery, where we started as barber surgeons.
Yes.
The first surgeons were truly barbers, right? When we go get a haircut, there's a barber's stick.
Yeah.
And that's actually, that's where we came from, right? The blood used to lick around the stick, and that's why it looks like the red that rotates around the barber's stick.
Very interesting history.
And to kind of contemporary surgery and medicine, where we use truly minimal invasive surgeries, robotic surgery, which has taken over our current practice right now, probably over 90% of my procedures are robotic assisted procedures. And the developments that's actively happening there are absolutely astonishing. Post-procedural artificial intelligence. Currently, within a very short period of time, we're going to have intraoperative assistance, identifying certain structures.
AI,
yes.
That's incredible.
It is very, at the end of the day, if whatever it is, if we can provide safer and better outcomes for the patients, I think it's our duty as doctors, as surgeons, to do that for our patients.
Excellent. Incredible. Well, this has been very exciting. This discussion, I'm sure, is going to be very popular among patients who watch this show. And it'll be on the airwaves as well as on YouTube. But I have to tell you, this is a real frontier. And the fact that you brought up AI is extraordinary, because we talked earlier about AI and cancer, AI and robotic surgery being the next step is very, very exciting. So I really want to thank you for joining us today. And do you have any last thoughts or things that I haven't asked you that you might want to mention?
No, thanks so much. I truly enjoyed being here.
Good.
I truly enjoyed finally meeting you in person.
Well, we enjoyed having you.
Thank you.
And with that, I'm going to say it's been a delightful program, and I hope you've all enjoyed listening to Dr. Talishinsky about the amazing aspects of obesity, weight loss, which I know is a very popular topic among patients, particularly young people. So thank you for being with us. And Dr. Talchinsky, thank you for being with us.
Much.
And we hope to see you all again at our next episode of Health Frontiers with Dr. Bob.
Thank you.
Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.